All right, I think we can go ahead and get started. Thank you everyone for joining our first 2026 home healthcare webinar. Our presenter, Amour Cornelius Dondi, is currently in his fourth year of doctoral studies in the Department of Environmental and Public Health Sciences at the University of Cincinnati. He holds a Master of Science and the Certified Safety Professional certification. His research centers on occupational exposures and safety protocols in healthcare environments, where he investigates hazard identification, exposure assessment, and control strategies. Drawing upon extensive fieldwork and interdisciplinary collaboration, Amour develops and validates evidence-based interventions aimed at protecting both patients and healthcare workers from chemical, biological, and physical risks. His long-term goal is to translate academic findings into practical safety programs and policies that improve health outcomes across diverse healthcare settings. And I'll hand it off to you, Amour.
All right, thank you. Good afternoon, everyone. Happy to share my findings on the research work that we've been working around 4 risk factors for patients or residents who reside in the home healthcare settings. We're focusing mainly on intrinsic risks. This will be the risks, the internal risks faced by the patients, and the extrinsic risk factors, which will be the environmental factors on the respective home healthcare setting that the patient or the resident resides. So a quick introduction or a background. Home healthcare it remains to be the fastest growing industry in the United States. Due to advancement in technology, most patients, elderly patients above the age of 65, according to the literature, are now preferring to stay at home and probably have the end of their life at their homes. And then you'll have healthcare workers in terms of nurses and nurse aides who will go to support the patients at their respective homes. Now, this fraction of healthcare workers who go to help the patients at home, at their respective homes, they do not have control of that environment. And so there could be extrinsic risks in the environmental setting, like poor housekeeping, slip, trips, and falls, risk factors that combined with the intrinsic risks can result to patient falls as well. For instance, in 2022, the number of patients who receive home health care was around 3.3 million, according to the CDC information. This kind of shows how the home health care sector keeps on growing. And then about 765,000 openings for home health care aides are projected each year. So you can see there's more jobs opened up for this healthcare sector. So once a patient falls, and a healthcare worker who is supporting that patient can be subjected to stress, can be subjected to abnormal postures, because the natural reaction would be to help that patient. So you would see the patient safety and the healthcare worker safety, be a nurse or nurse aide, kind of goes hand in hand. If we have more falls happening, that can be a burden as well to the healthcare workers. So the aim of this research was to kind of identify those risks, and in the long run, create or suggest for a fall prevention management system or strategies that can be effective for the patients, but also subsequently have a positive effect to the healthcare workers or the caregivers who are supporting the patient. In 2024, home health and person aides held about 4.3 million jobs in the USA. These are statistical information to kind of show you how this healthcare sector keeps on growing at a fast-paced rate. Okay, now falls. The healthcare community is deeply challenged by patient falls. These healthcare communities in hospitals, in long-term care facilities, subsequently home healthcare settings, experience patient falls due to, again, intrinsic or extrinsic risks. And these fall and fall-related injuries are a major patient safety problem in healthcare. Different literatures have shown these falls, some of them will result in injurious events, and some of them are non-injurious, and some falls even result into fatal cases. And this remains, again, to be a challenge in the healthcare sector. it is estimated 20% of fall-related deaths occur in the older population. Now, from the literature, patient falls in home healthcare settings and even long-term care settings is affecting mostly the elderly who are 60 years, 65 years and above. So when a fall occurrence happens, it also affects the caregiver. In this case, when we talk of a caregiver, could be the nurse aide, the nurse who is supporting the patient, or even a family member who stays with the patient. Now, when the natural reaction of any caregiver when you're supporting your patient when they're about to fall, your natural reaction will be to help them and assist them. If there's more occurrences of falls and you do that, you're subjected to what we call a postural demand, and that has shown from the literature has shown to result in different work-related injuries, particularly the low back pain. As you will know, amongst other causes of low back pain, patient handling tasks have been one of the most cited issues that can result into different work-related injuries. Now, when you do the patient handling tasks, such as repositioning the patient, supporting the patient mobility, but then handling increased frequencies of patient falls, that may result to a problem, serious problems to the caregivers. And caregivers also must help get the patient off the floor, and this again results in awkward postures, poor lifting mechanics, and high loads, which can also result into health issues for the caregivers. So as I said in the beginning, these two safety issues, patient safety and healthcare worker safety or caregiver safety, kind of go hand in hand. And this sentence kind of summarizes what I'm trying to say. More falls equals to more injuries for the respective caregivers. So findings in this research and recommendations in this research have a positive impact in the healthcare setting. So our objective was to first evaluate the intrinsic and extrinsic factors that can result to patient falls, and in the long run, kind of look at the subsequent burden to the home health caregivers. The subsequent burden to the home health caregivers, it's a research that's going on. Once we have our findings, we'll come back, but just to give you a highlight of what we're doing, we're basically doing the postural demand study using wearable sensors, the X-Sense system connected to the motion capture system for the caregivers in the long-term care facilities. And then we'll move to the home health care settings and kind of compare. But in evaluating the intrinsic and extrinsic factors in the home health care settings, this was our specific aim, and how we did that, we had to recruit the respective home health care, and we did that by using flyers. We sent a lot of flyers to different home health care agencies here in Ohio and Cincinnati. We did in-person visits, walked in and talked to the nursing directors and the leadership, kind of explained the study and how we believe it will be a positive impact. This study was approved by the UCIRB. So our inclusion criteria in assessing intrinsic and extrinsic falls in the home health care, we recruiting men and women aged 60 years and above, because the literature showed that it's this fraction of the elderly who are experiencing frequent patient falls. They must have been in a home health care for at least 2 weeks and above. This will kind of show they are already used to that environment, and they will be able to tell us some of the hazards or some of the risks they've encountered, and even different fall events that must have occurred and why they occurred. Must have no fractures of lower extremities or the torso, no major surgeries in the last year, and we are looking for participants who are able to read and understand English for the purpose of consenting. So the assessments, we did utilize different assessment tools, which were kind of discussed more from the literature. The assessment tools were able to capture the intrinsic risks, which are internal factors by the patient, such as the cognitive function, mobility deficiencies, vision impairment, which are known to be, or the fear of falls, which are being discussed as the most intrinsic risks that can result to patient falls. And the other questionnaire or the assessment tool was, I'll talk about it in the next slide, but was capturing only the extrinsic risk. We were walking around the rooms, walking around the dining rooms, break rooms, to try and see what were the obvious extrinsic risks or the environmental factors that will then subsequently result in patient falls. So the first assessment tool, just talk high level, was the demographic questionnaire. This was intended to capture the information, demographic information of the patient that consented for our study. This was looking at the age, gender, the respective living conditions, and various intrinsic risks, like he was asking whether there were vision problems, if there was chronic health conditions, if the participant was under medication, and most importantly, it was also capturing if the participant experienced a fall event in the past year. And then we're looking at where that event happened, just to try and see exactly if it's environmental conditions. And we were capturing the number of falls for every participant. And then fear of falls, as I said, is one of the intrinsic risks that have been highlighted in the literature to be the major cause of patient falls. So to capture the fear of falls, we used the falls efficacy scale, which primarily had 10 basic daily activities, and participants were just asked about their degree of concern or their fear of falling when doing those tasks. It was kind of graded, with 64 being the most extremely worried, and 16 being not worried, based on the number of scale we had. And then the timed up and go test, this was basically utilized to capture the mobility issues for the patients that consented for the study. In doing the timed up and go test, basically the participant was given a wooden chair and was asked to stand up comfortably and walk in a safe pace for 3 meters, turning around and returning back to the chair and sitting down. Then the total time for all that task was captured, just to understand how fast or how slow they are, and that could tell us their mobility issues that they're facing, which could be another reason for another intrinsic risk, internal factor for a patient fall. CAT's Index of Independence and Activities of Daily Living is another tool that has been highlighted in the literature, which captures the level of independence or dependence that the participant has in activities of daily living, like bathing, transferring, toileting. So this checklist was able to identify how independent or how dependent the participant was, and then this would give a clear picture how risk they were in terms of in relation to patient falls. The mini mental state examination questionnaire, this was another tool that was used to assess the cognitive function and ability of the participant. Basically, it was capturing 5 core areas of cognition, which are, orientation, the ability to remember or recall, registration, attention to details, and some language issues. So this was 11 questions, and the participant was asked those questions. So 2 questions were repetitive, just to understand how they could be able to recall, because cognitive functions or cognitive impairment has also been known to be another intrinsic risk that has resulted in patient falling across different healthcare settings. Hip and knee function test, this was done using the requisite ergo-functional test. This was just basically capturing how participants were facing issues with the hips and knees. What was that pain level when they woke up? What was the pain level sitting for 2 hours? What was that pain level when they had to move or locomote from one area to another? It was also a Likert scale, and the lower the risk was related to the high risk of patient falling. T-net balance tool, this was capturing 2 issues, the gait and the balance assessment. Participants were asked to go through a series of different tasks on the questionnaire, and which were also scaled to identify if the gait and balance issues were okay, because these are also intrinsic risks. Then we did the strength and muscle power of the limbs. This was another task. Participants were asked to sit in a wooden chair and then sit and stand 5 times, and we were recording the total amount of time in seconds when they were doing this task. Again, this was another tool to kind of show or support their ability to locomote and their mobility issues. And finally, in identifying the extrinsic risk, which will be your environmental factors, we use the Westmade Home Safety Assessment Tool, and we're going around their home environment, their rooms, dining rooms. We're going around break rooms, physiotherapy rooms, looking at different hazards, environmental factors. Like I said, slip, trips, and falls. We're looking at how high the beds were, the bed height, and we're looking at how low they were, because all that can be environmental factors which may result in patient fallings, the wardrobes, and the general arrangements of the room, and seeing any risks. And we were capturing the frequencies of the risks we saw. So the procedures on doing this research, the first was definitely consenting interested participants who agreed to take part in the study, went through an informed consent. Principal investigator, in this case myself, I was able to go through the items of the consent, give a little room for questioning, and then once the participant remained interested, they signed the consent, and I also signed it as well. And then this was followed by the demographic survey to get the demographic information, and then we completed the assessment tools that I've just discussed, and at the end of the study, an incentive was provided to the respective participant. Like I said, the settings where we collected this data was in senior living communities. This was right in Cincinnati, Ohio, in Springdale. And, you know, the healthcare community led us in, and they were very supportive in the overall data collection. And they kind of advised different participants to take part in this study, because they acknowledged that patient falls was also a problem that they currently face at their respective settings. So that after we had collected all the data, we completed descriptive statistics in terms of completing frequencies, means, and percentages, and ANOVA tests were used to compare the continuous outcomes. This the chi-square, I'm not going to present it here, but this was we did this study also for the long-term care settings. So we did the chi-square to compare the results between the two healthcare settings. But since this webinar is only home healthcare, I will not present that data. So the results, overall, we had 20 participants who resided in the senior living community, and 10 out of the 20 participants reported to have experienced falls in the period of 1 year. And if you look at the demographic information, it was an elderly group with a mean age of about 86 years. Most of them were females, about 3%, and they were living alone in the respective assisted senior living environment. In terms of the intrinsic risks, most participants reported to have chronic health conditions, and they were under medication. They were taking medicines, and this was related to the information. They said that having chronic health conditions and taking medications was somehow causing dizziness and eventually patients falling. But also vision problems was another highlighted intrinsic disorder that they reported to face some vision issues. And like I showed, 50% of the participants experienced falls in the past year. Now, looking at the intrinsic risks, you will see that the mini mental state score, the mean score was 27.5. This was really a serious intrinsic risk that was related to the patient falling, because of showing that there's cognitive impairment issues, as well as both the T-native balance and gait scores were quite low, showing that there's a risk of mobility and balance, eventually the patient falling. But also fear of falls in doing different tasks can be a reason of patient falling, and most of those patients reported to have the fear of falls. These were the most captured intrinsic risks, and again, increased times for time up and go test. That is showing they take a lot of time in moving 3 meters, and given that a longer duration in doing this task was linked to mobility issues, showing this can also be a risk for patients to fall. In terms of the extrinsic risks, the lighting, steps and wardrobes were kind of linked in terms of frequencies. We observed some issues around those, even though we'd say overall the senior living community was in good condition, well kept. So the extrinsic risks were not that much compared to other long-term care facilities that we visited. However, we could see some other risks that can result in respective patient falling. So as I said, the key intrinsic factors, there were significant physical vulnerabilities, which were demonstrated from the TOG test, from Tinetti balance and gait scores. The mobility and balance were notably impaired, and these low scores on this Tinetti and balance test were linked to patient falls. And then the hip and knee function and the limb strength showed diminished strength capability, and this can really result in patient falling. Now, story here is that the patient will have these issues, but then they will try to be independent because they're used to being independent. Like getting out of bed, a patient with diminished strength and capability will definitely need help from a caregiver. But when they wake up in the morning, they will not call for help. They will try to do it, to go to the bathroom by themselves. And then as they get out of the bed, they fall down. So there was that gap, which was between the caregiver and the healthcare and the patient giving information to get support. So about 5 or 6 falls were related to such a scenario, showing that they need to be a system that can bridge that gap, where the caregiver is able to get the information promptly and support the patient. And then the functional mobility test, like I said, it was a long time for the timed up and go durations, which shows diminishing strength capability. And all these were the potential indicators for increased fall risks. And the key extrinsic risks, some rooms had poor lighting and uneven loose surfaces. So these are environmental factors. Now, if you look at the human factors with diminished strength, if you link the two, then definitely the patients will still experience falls if we don't take control measures or stringent management systems that will protect the patient human factors, but also control the environmental factors. And the footwear, some patients had slipperiness of socks and shoes, which cause sleep risks and increase the risk of trips as well. And then we observed cluttered and cords around the homes, which were trip hazards in their respective rooms. Now, potential interventions. We feel that based on the findings that we've had in this study, there should be a routine and standardized screening, utilizing these tools such as the mini mental state examination for cognitive assessment, timed up go test or Tinetti balance and gait scores for physical mobility, and structured medication review. If these key intrinsic factors are well screened, and then the patients with high risks can then have more care and more support from the caregiver, in a way that we're able to bridge that gap and make sure that the patient doesn't try to be independent because they're not at that level yet, but they have constant care from the caregiver, enough support, enabling them to locomote or move without falling. And then human-centered integration of technology with the world evolving in artificial intelligence. If we can get sensors and alarms that are tied to workflows to avoid alarm fatigue, to have those workforce supports, enough training for the workforce on how these AI sensors can proactively capture these risks before the patient falls. This would bridge that gap and help the patient and subsequent help the caregiver. Future directions with this study, one could do longitudinal studies, long-term studies that would show the modeling, which would give the link, the causal link between the intrinsic and the extrinsic risks and the patient falls in the respective long-term care settings. And then could have a pilot comprehensive study that would look at technology, engineering controls, and environmental controls, and how this can, in a real-world environment, reduce patient falls, and pilot and assess AI-enabled sensing and environment assessment systems for real-time hazard detection and adaptive prevention. These are three key areas where this study can go further to bridge the gap between patient safety and caregiver safety. In conclusion, we feel that falls are multifactorial. That means they result from the interaction between intrinsic risks of the patient, which then are the human factors, and the extrinsic risk factors, which are the environmental factors. Human factors perspective, yes, there's that capability and demand mismatch, whereby the patient, from the human factors perspective, has diminished capabilities to do certain tasks, but the demand is high. They still need to do something. So as they try to do it independently, due to the diminished capability, end up falling and getting serious injuries or even fatalities. So if we can have controls, like I said in my previous slide, where they kind of capture two aspects, the human factors and the demand capability from the staffing, to bridge that gap and create fall prevention strategies that can protect the patients who are falling from the age of 65 and above. And then also have environmental modifications, optimized bed or chair heights, and non-slip surfaces, regular housekeeping by the caregivers, take control of the wire cords and other obvious housekeeping issues that can result in patient falling. So this study was hugely supported by the National Institute for Occupational Safety and Health through the Pilot Research Project Training Program of the University of Cincinnati Education and Research Center. With the grant that they provided, we were able to travel, we were able to have incentives for the participants, and we were able to collect the data timely. And I also want to acknowledge our supervisor and mentor, Dr. Davis Kemet, who has guided us through this research. Our research is still going on. We're collecting data in different long-term care settings right now to compare the two, but we're also looking at the healthcare workers' burden, how they're being impacted by the patient falls. We're doing structured interviews. We're also using wearable sensors to get the objective postural demand experienced by the healthcare workers when they're doing patient handling tasks. And I thank my colleagues who were part of the same lab, low biomechanics lab, Dixon, Rungere, Mercy, Omoifo, Robbie, who have supported a lot in data collection and concept of this study. And also want to thank the home healthcare agencies who opened the door and let us in to collect the data. That's all I had prepared for you. I'm happy to take any questions. Thank you.
All right, well, if we have no questions, thank you everyone for attending our first home healthcare webinar. This will be an ongoing series, so I'll send out a notification for our next webinar that's going to be in May soon. But in the meantime, I'll be sending out a survey following this presentation. If you do need CE credit, then you can fill out the survey, and then certificates will be sent out following that. Thank you again, everyone.
Thank you.